Yes, well, I'm delighted. I was delighted to, on behalf of my co-authors and co-investigators, to present the first results of the NEOPRISM colorectal trial as a late-breaking abstract at ASCO 2024. So I'm the chief investigator of this study, and I thought about this study around 2019, and it took a little while to set up for various reasons. But we managed to open this trial in July of 2022. What is the trial? It is giving preoperative immunotherapy, just 9 weeks, that's 3-weekly pembrolizumab immunotherapy for operable high-risk stage 2 or stage 3 MMR deficient MSI-high bowel cancers. Now, the idea was to maybe add to the data of other studies, which we've already shown that 4 or 3 months of doublet immunotherapy or single immunotherapy is very good. But this is the first trial where we also stratify the treatment according to something called tumor mutation burden prospectively. And the idea of tumor mutation burden is that we know in more advanced disease that this high neoantigen load may allow a better response to immunotherapy, but we've never tested that in the early stage setting. So we recruited 32 patients and across 4 to 5 sites across the UK, and very rapidly indeed. And we gave immunotherapy to all 32 of them. The design of the trial was that we would give 1 cycle of immunotherapy whilst we did some extra profiling, including extra trial colonoscopies and blood tests and microbiome, and then use those tests longitudinally, pre-cycle 1, pre-cycle 2, pre-cycle 3, pre-op and post-op, but do surgery about 4 weeks after the last cycle of treatment, and then after surgery decide if they needed or wanted adjuvant chemotherapy. The primary endpoint was pathological complete response. That means complete disappearance of the tumor in the bowel wall and the lymph nodes. And the secondary endpoints were relapse-free survival at 3 years, overall survival, safety, and health-related quality of life. But the other translational endpoints were by doing all those tests to see whether there were other biomarkers, which we desperately need for our patients, to decide, whether we could predict such good responses. And indeed there were. So we achieved a 59% pathological complete response rate in 32 resected primaries. All bar one was TMB high, and all of them, did very well from a surgical point of view. The other thing is that it was very well tolerated. Only a few patients had grade 3 side effects. And the main problems were the bulkiness of the tumors, that they were big and bulky, and they caused the patients anemia, nausea, and pain. And then also after surgery or pre-surgery, there were a few complications, but all very manageable. What we also showed in the study was that a few cases where there was such dramatic responses, shrinkage, that the tumor kind of melted away through the bowel wall and caused a fistula, or actually didn't melt away, but caused stricturing and caused narrowing of the bowel to make the bowel obstruct. So the surgeons, rather than doing their elective operation 4 weeks after immunotherapy, actually had to do it like urgently within days. Yet the patients actually did very well. They looked like they're bulky tumors, but there was no cancer left in the specimen. So it's obviously a really good trial for the patients. They've all been happy they've been on it. And because of these very good results, we are expanding the trial to achieve a 3-year relapse-free survival endpoint. We're also still doing a lot of translational work, which we hopefully can show in the next kind of a few years or conferences. I think that it just adds to the kind of weight of data that neoadjuvant treatment seems to be extremely good for a lot of our cancer patients, particularly immunotherapy in patients who are MMR deficient. So yeah, those were my main results. I think it's still early days because this trial is only 32 patients. And as I just said, we do need more patients to really know whether there's a definite new standard of care. But as I said, there have been other trials already, something called the NICHE and NICHE 2 trials, NICHE 3 trials, and indeed the rectal dostarlimab trial that shows that these immunotherapy drugs seem to be extremely good at shrinking down these early stage cancers. And there's even already to talk about, well, how can we randomize these patients if already single agent or double immunotherapy is so good? because the standard of care is normally surgery followed by chemotherapy. But there are those trials coming out, and it'll be interesting to see which kind of wins out. I think the other thing is that, we think the neoadjuvant setting will give us answers more quickly. And I think this is what the patients want. They don't want to wait. And, these patients are very well read nowadays, about the power of immunotherapy. So I do think that the implications are, in this particular trial, a little early to say what becomes standard of care, but I hope it adds to all the weight of data that really patients who have this particular genetic subtype, MM1 deficient MSI cancer, should be accessing immunotherapy early or earlier, and in particular, trying to get them into clinical trials so we can get those answers much more quickly to decide whether it will become a standard of care, not just in the UK, but globally.